My name is Shruti Katari. I am the Director of Industry Initiatives for Blue Shield of California. And what we do is we focus on healthcare transformation through policy movement and innovation scale. And we do that by industry collaboration. And so that is a huge theme of today. We're talking about birth equity. And what a targeted time to be talking about this topic. For those of you who may not be following, yesterday, Governor Newsom did sign SB 65, which is the California Momnibus Act, and that aims to close existing racial gaps in maternal and infant mortality. So this is super exciting legislation, which furthers California's commitment to supporting maternal health and advances states' equity goals and really addresses systematic racism. So this is important also because when we look at the data, since 2008, California has been focused on reducing maternal mortality, and the rates have dropped about 55%. However, for Black mothers, they're still 3 to 4 times more likely to die in childbirth in the state of California. So this is pretty egregious if you think about this, right? And studies have consistently confirmed that, and they've confirmed what many with lived experiences have said, which is that it's the stress and systematic racism that exists in our system that really is the cause of this. And that's in and outside of our healthcare system. So that is what we're talking about today. We have a group of different industry leaders here today, and they're going to be talking about what they're doing to support maternal health and to advance Black maternal health specifically. We have Kendra Montgomery Block, who is the Vice President of Diversity, Equity, and Social Impact for the Sacramento Kings. We have Melissa Hanna, who is the co-founder and CEO of Mommy. Didi Janice, who is the VP of Blue Shield of California for the Health Transformation Lab, and Dr. James Kyle, who is the Medical Director for Quality, Diversity, Equity, and Inclusion for LA Care. First of all, I would love for all of you, you all are so impressive. So please introduce yourselves. Tell us a little bit more about who you are. We'd also love to hear about your organization. And if you can provide specific examples of what your work is in supporting Black maternal health. Melissa, why don't we start with you?
Hi, everyone. I'm Melissa Hanna, co-founder and CEO of Mommy. Mommy is an integrated care delivery platform for maternal and infant health. And we work with healthcare organizations, community-based programs, allied health professionals, and health systems of all sizes across the United States to create perinatal connectivity that links together all of the historically fragmented components of the maternal and infant healthcare journey. We focus on the period of time between conception all the way through baby's first year of life, which is really where we see the highest rate of mortality and morbidity for Black infants and Black mothers. And so this is a particular focus for our organization. And our lens on health equity starts with partnerships with perinatal health-focused community-based organizations. So we work with allied health professionals, doula programs, community advocacy, and pregnancy coach type programs across the United States. And I think we're going to talk about some of that work in more detail today, but I see some names from the organizations that work with Mommy and use Mommy software as part of their perinatal connectivity efforts across the US. So shout out to everyone on today's conversation that is already familiar with our work and using it as part of your efforts to change these outcomes for the better for Black moms and infants.
Love that. Dr. Kyle, how about you next?
Sure. Good morning, everyone. I'm James Kyle. I'm the medical director for Quality, Diversity, Equity, and Inclusion here at LA Care. LA Care has 2.3 million members here in Los Angeles County. Basically, 1 out of every 5 or so LA County residents is one of our members. The whole issue of Black maternal mortality has been extremely important to us. I am a survivor myself, personally. My mother was told when I was born that either she or I would die. We surprised them, and we both survived. But I recognize the access to a healthy birth and healthy birth outcomes for Black women is extremely fragile. And so at LA Care, we're focusing our efforts now to collect data, to initiate programs we can talk about later to try to address this. So I'm very happy, and I see the names of people on the chat. I'm just so impressed with the quality of people who have joined this conversation. We are humbled by your presence, and we're glad you're with us.
So hi, I'm Dee Dee Johnnies. I lead Blue Shield of California's Health Transformation Lab. And honestly, this issue, Black maternal child health, is, I tell people, it's my why, right? It's why I'm in healthcare. It's why I left advertising to come and be in healthcare. It was not for the fun. I was leading health innovation, leading work that was supposed to remove barriers to good care at another health organization when I had my daughter. And I tell people all the time, healthcare almost killed me. And I was so angry. It almost killed me and my daughter. I should say bad healthcare almost killed me and my daughter. And it's my why, right? It's the reason that I said I was going to quit. I'm like, how dare I be an executive in this organization and not get good care, not have people listen to me, not have people see me, and how much pain I was in and how much danger I was in. And then I just decided when I got up out of that bed, no, you will not be rid of me. You will find me here every day trying to divert resources, trying to convince and convey and get people to listen to moms like me. And so I get to do that work. I get the privilege of doing that work by leading the Health Transformation Lab team, which includes the population health equity team, the community health teams, and a host of teams who are focused on partnering with many of you here, and also internally across our organization to try and remove barriers and remove inequities from the maternal care system. And we'll talk a little bit more, I think, about initiatives, like specific initiatives, but that's my why.
Good morning, everyone. Kendra Montgomery Block. I am about 60 days into a new position as the Vice President of Diversity, Equity, and Social Impact at the Sacramento Kings. Prior to that, I worked as a Senior Program Officer for the Sarah Health Foundation here in Sacramento, really building across California what we call the Black Child Legacy Campaign, which focuses on reducing preventable African-American child deaths. And in that, we really started to look at what were the reasons why Black kids, Black infants, Black youth were dying, and in which ways. And there are four main ways around violence, gun violence, Sued's death, and child abuse and neglect. And that fourth one was perinatal conditions. And there's a lot of data and research. We were able to really use the collective impact approach over the last 7 years to not only impact death data, but to also impact the ethnic kind of breakdown of that death data. But in that, we have not been able to move the scale around perinatal conditions. And that really is where I came to the intersection between Black maternal health and the healthcare as we know it. And so a lot to talk about on that, and I will get into it a lot more deeper, but excited to be on this panel. Thank you, Shruti, and all of the Blue Shield folks for having us. It's going to be a great conversation.
I want to talk more, Kendra, you're bringing up some great points around data and outcomes of where you have seen the needle move and where you haven't. So let's talk about that a little bit more. In the initiatives that you all are leading, can you talk about some of the outcomes you've seen, both qualitative and quantitative?
And our goal really wasn't set out in 2015, the Black Child Legacy Campaign, again, focusing on those four preventable causes of death, said, hey, how can we use public health as a strategy to not only create collective impact in neighborhoods that were experiencing this type of egregious preventable deaths, but how can we really create an awareness campaign and get in front of some of these kind of issues that have been plaguing our communities for a long, long time. And so through our efforts, we were able, not only our central goal was to reduce preventable African-American child deaths by 10 to 20% by the year 2020. We were able to exceed that about 40% in preventable death causes for African-American families. And again, it wasn't just Black families that were being impacted in a positive way, but it was all families. That kind of John Powell's work around targeted but universal in the way that we deal with families that we know are in crisis holistically. We were able to really use that data to continue to drill down in those neighborhoods that were most impacted, use that as a way to, again, build awareness, but also build your skills, your attitude, and your knowledge around public health and the systems, not just at the county level, but deep in neighborhoods that have trusted messengers and walkabouts. So, like I said, we are really great on gun violence deaths. We were able to eliminate that for 30 months in the city of Sacramento prior to COVID. That is 0 juvenile homicides, zero juvenile gun homicides for 30 months. We were able to really quickly go in and make sure that all of the leading healthcare hospitals here had one main cause or question when it comes to how do you sleep your child alone on your back and in a crib. And if those parents that were giving birth at those hospitals were not able to have that, give them a crib. And I just say that all of those were kind of low-hanging fruit pieces that we were able to do by building a strategy around with public health, public and private. Where we again came to the intersection is what were we going to do around perinatal conditions? And we could not have an impact around perinatal conditions unless we first started to talk to the mothers that were giving birth to these children or sometimes not giving birth and what are their lived experiences. And again, we did not move the dial on that. And that's kind of where me and Lay come into this conversation around building a perinatal Black maternal health strategy.
I think when looking at Los Angeles County, the numbers are disappointing. I don't think we've made the kind of progress we need to make yet. And I'm not even sure we have our hands wrapped securely around all of the data we need to have. Who are these mothers? How many are there in a given day that are at risk for bad outcomes? How do we get to them early enough in their pregnancies to try to have a difference? All of these are questions I think the health plan, the county of Los Angeles Health Department, we're all looking at these issues. I think what we see right now, based on the data we do have, is a call to action. We've got to do more than what we're doing. And if we're just satisfied with small incremental changes, we'll never turn the tide. This is going to require a disruptive change on the part of all of us collectively to try to reach out to Black mothers and try to save their lives and the lives of their children. And if that doesn't happen soon, we'll see the same kind of results that would go on for years and decades. And that's just it's just unacceptable.
I can speak to our work at Mommy and the kinds of outcomes that we are focused on achieving, both through the platform directly and through the way that the technology is built, but also specifically through amplifying the efforts of community-based programs that are right there in the neighborhood. You heard Kendra say walkabouts, visiting families at home, in community centers, in churches, in safe spaces where they can start to share more of the challenges that they're facing and the places where they may feel least heard in their healthcare experience. And that can be a challenge overall. There's been there are a lot of efforts now and a lot of campaigns out there around listening to Black mothers, hear her, listen to her, pay attention to her needs. And yet there are still major gaps in our healthcare infrastructure that prevent even the active listener who is sitting in front of that mother in that moment in time from being able to take action on that information and really sort of to share that information and collaborate effectively to create the most impactful intervention in that moment. And so a lot of the, when you start to unpack the data around maternal mortality and morbidity, specifically as it relates to Black and African-American women, what we start to see is that someone in the story knew something wasn't right. That this is not, these experiences are not happening in isolation. There was a difficulty, there was a clinical concern, there was a social need, there was a lack of trust between patient and care provider. There was something that should have been worked on and addressed. But if that data can't come to the light and be seen transparently and addressed honestly and in earnest, then we're going to continue to see bias and systemic racism infiltrate this infrastructure and block our ability to make change. And so some of the things that we look at Mommy in the way that our platform is implemented. So we're very mindful that perinatal connectivity doesn't mean just connecting the EHRs and the sort of the information systems of major healthcare organizations, although that is a part of our work, is to connect the dots between major medical centers and payers and health systems and large networks of providers. But that's only half the battle, because much of the care, especially when it comes to maternity, one of the things that's most, I think, interesting, exciting, and special about maternity is that it happens outside of those buildings, that it happens in the home, it happens in the community center, it happens in the neighborhood, it happens in the park. And so working with organizations and working with professionals who are there in those settings is actually one of the most critical components to resolving these egregious metrics that we see across the country. It's the connectivity between what we would call sort of the folks on the ground, the boots on the ground, and the people that are in very large organizations who want to make change, and many of whom are on this call today want to see change, but are not necessarily in the best position to implement it themselves. And so partnership and collective impact are key elements of that. And balancing, for example, within our network, who's sort of on each side of the playing field, and creating that patient-centric experience where we've got a mother-baby diet at the center, but we've got a lot of key players who maybe individually cannot change the metric on their own, but collectively can do that. And so bringing them together into one platform is a big part of that. The other big thing that I would say, though, about outcomes is that we're talking about access to care, and we're talking about expedient access to care, because it's not like there's not a lot of people who want to do this work. And it's not like there's not a lot of people who are capable and credentialed and empowered to do this work. The question is, can we get the patients to those people fast enough? And so even as there are efforts now, more so than ever before, underway to produce more professionals specializing in maternal and infant care, in maternal mental health, we're seeing more folks than ever get the PMHC credential, perinatal mental health. We're seeing folks become doulas and go through doula training programs, pursue midwifery credentials, and move into lactation and infant feeding programs. We're seeing a lot of that activity, but we also need to figure out what that timetable is between someone expressing a need that they may not even know is the first sign of a clinical symptom or a risk that could become a stat we don't want to have, and how we actually get that person into care. So these are some of the things, and we do a lot internally as a tech company analyzing this, but more than ever, what really matters is actually how you connect people together. So the time it takes for someone, for example, to sign up into the Mommy platform, to actually get connected to a care providing organization within their community, and then actually get access to care, whether that's happening virtually now during the pandemic or in person as it was before the pandemic. And now we're starting to see in some communities that in-person care coming back on, coming back into the mainstream. However it's happening, it is about that time to care that is critical, especially for Black mothers.
And with Blue Shield, I think we're not different than any of our partners who are seated here, meaning that we recognize that we have to take a multi-front approach, that we have to coalition, and we also recognize the same as all of you, right? We're tracking all the same metrics, and we're all, equally frustrated with the movement that we're seeing. Specifically, though, some of the work that we've been doing is, we're trying to partner at all levels, right? So part of the California Maternal Quality Care Collaborative, group of other payers and other folks who are dedicated, right, to improving California maternal care. We're working with the Blue Cross Blue Shield Association. I don't know if you guys tuned in, but back in May, they actually held a conference to express the Blues commitment to decreasing the racial health disparities or outcomes disparities for Black women over the next 5 years. And there's an awesome report. You should check it out. But for our team too, these are some of our partners, as I've mentioned here, but in Sacramento and LA, we are working with many of the partners you're talking about, community health advocates who are doulas, using digital care coordination platforms to connect them to the services, the information to support, doing Black maternal health circles, right? Trying to get moms together, not just for one another, but honestly, we got a lot to learn, right? I mean, I know this Black mom's story, this Black mom's experience, but I can't peanut butter spread it everywhere. And we also owe, I think, and I think all of us will say it here 1,000 times until people are tired of it, we owe Black moms, Black women, listening to them, like really listening, not validating that what I'm already doing is good or not good, but actually thinking about how we bring about the things that really would move the needle for them in terms of their experiences and their outcomes. And then, I won't belabor the point that, we are all probably tracking the same data, right, on patient health, on listening to moms and getting patient reported outcomes and experiences. But what I will layer on the data is the data part about us getting to know who is a Black mom and who is not. Like, I think that's one part that we talk a lot about. Tell us so we know where you are, so we can measure disparity. But I don't think that we spend enough time talking about what I think Melissa talked about, which is the leading indicators, right? The stuff that tells us long before there is a morbidity or mortality stat, long before there's tragedy and trauma, the stuff that tells us, Houston, there's a problem, right? And it's not always a problem with the mom. Yes, there are access problems, but some of those access problems are ours, right? They're network adequacy problems, they're network diversity problems. They are knowable problems with a provider and his or her patient relationships, right? These are things that we probably need to get more creative. If we don't have direct knowledge, we need better proxy indicators for the things that we should be looking for, those hotspots, those nests that are producing bad outcomes that then become compounded bad outcomes for Black moms. And so I implore us to, yes, think about new ways that we go out and collect data and from Black moms and double down, triple down on listening to Black moms and designing things with them that they really need. But I also say we have to share our data, right? We have to tell who it is that we have lined up to support you. How adequate have we made your options? Have we given you a choice of providers in your market, near your home? Have we covered it appropriately for you? Those are things that we need to be able to not only, do, but we need to make the information available to you. We need our own transparency. We need to pay off on the ask of, if you tell me more about you and what you need, then I will do what?
Love that, Dee. And I'm going to ask a follow-up question to all of you all about what you talked about with sharing data. But before I do, Melissa, you shared a story when we met a few weeks ago about a case study of a woman who was told by her surgeon to go to the emergency room. Can you, if you feel comfortable, can you share a little bit about that? I thought that was a very powerful case study of listening, Dee, what everyone has really said.
Absolutely. And I think that when we talk about listening to mothers, there's an extension really that shows in this story as well, which is listening to other providers who are caring for Black mothers and start to take all of the concerns more seriously. If for no other reason than the stats are, I use this word already, egregious. I've got many other words for this: horrible, terrible, terrifying. There's just no way around this. We've gotten to a point now where there is an absolute inevitability of change, because going more in this direction is actually disastrous for our country in many ways, economically, health-wise, socially. It's really actually quite frightening. So we have to make change. And the story that you're referencing, Shruti, is just one of so many that we have from working with patients through our platform and working with the providers who are supporting them. In that particular experience, we have a Black mother who was first pregnancy, first delivery, with a 3-week-old baby, having received breastfeeding support through a lactation consultant who is using Mommy. At the part of the platform is that we are an EHR and CRM for local and independent allied health professionals and maternal healthcare providers. And so we have basically a charting, documentation, booking, scheduling, telehealth tool set for a variety of different kinds of maternal health professionals. And in this particular case, she was receiving care from a lactation consultant, documenting and charting her care and communicating with her through Mommy. She messaged her lactation consultant and said, "I'm feeling severe pain in my breast and it's seeming red and inflamed. What should I do?" The lactation consultant is providing care, but identifying that this is now likely something that really needs to be reported to her OB, potentially because there needs to be a prescription for antibiotics. At this point, with enough information, a photo came through of the breast. description of pain, how long it had been happening. The lactation consultant did their part of this storyline in the platform. Everything is documented there. The recommendation was, let's engage your OB. Patient contacted OB. OB assessed the situation and said, it doesn't seem like you need, anything else just yet, but some comfort care and treatment. That was not enough. 24 hours later, patient calls back and says, I actually need antibiotics. This is more of an extended version of the story. There was actually a prescription made for antibiotics. So OB did what OB felt like was the appropriate thing at that time. And I think at that moment, everything kind of looks kosher. It goes downhill from there. It was within 48 hours of that point in time, the infection had not gotten better. And so the patient contacts the lactation consultant through mommy and asks for more help and says, I don't know what else is going on. Is there anything else I can do? I'm already on antibiotics. The lactation consultant makes a referral through the platform to a breast surgeon that is part of this patient's network. So this is a breast surgeon who is part of this affiliated health group. The OB sanctioned that. It's like, yeah, that's okay. We know that person. Let's get that second opinion here. They did a virtual consult. At that point, the breast surgeon said, it is likely that you are experiencing a breast abscess. I cannot provide any more care to you virtually. I need you to go now to the hospital. Patient goes to the hospital and says, I was just told by a breast surgeon that I need to be here. My OB has me on antibiotics. It's not resolving. I'm in excruciating pain. I cannot breastfeed my 3-week-old baby. They sent her home. They said they didn't see an issue and it didn't seem that bad. And they were not able to identify on monoracial Black skin, even though 3 other providers said, there is something not quite right here, you need to go in. And we're talking about a physician directing the patient to go in. Why was this patient sent home? Well, here's the end of that story. The next evening, that patient was admitted to the hospital for a 2.5-day stay for a more expansive course of antibiotics and to have that abscess drained. Now, I see someone has said, when will we believe the pain of Black people? Let me count the ways that this story is messed up, right? If you can't already see the obvious one, we talk about training providers, but who needed to be trained in this situation? A lot of people would have said, I did my part. So what else could we have done? Well, obviously at the end point here, we're talking about an admission that did not need to happen. We're talking about a morbidity stat here, a treatment, a procedure that occurred, a breast infection that, as far as this patient's concerned, she said, this was miserable. I don't know. By the way, she can't breastfeed on that breast anymore. So she's now pumping and breastfeeding on one breast and questioning how long she's going to be doing this for. So this is what her story is now. And you have a provider at the end of this that was in a hospital setting who was not trained to identify mastitis that had become an abscess on monoracial Black skin. You also have a provider, you have a specialist who maybe was also not trained on how to advocate for this Black mother and ensure that she received the care that they had already determined that she needed to receive. And this is the difference when we're talking about how to take action in a way that is thoughtful and specific to these metrics. We can't just say to providers, make the referrals, document, send the patient to a specialist. You have to go above and beyond, and you have to think about what is the risk if I do not do everything in my power to make sure this patient gets treatment now. When we talk about access to care and speed to care, this is a small step that it's not to malign any particular player in this, although I am upset with a lot of this story. It's to say, where are the places that someone else could have stepped up and done a little bit more because we're talking about a Black mother in the story.
I find that case study, the example really powerful, because I think we hear things like listen and, where it could feel like a little glossy, like, what does that mean? But you have very tangible moments in this scenario of where you could have had better systems in place and processes in place. So, question for you all thinking about that. Leaders have called recently for integration of health equity into value-based payments, into reform of our delivery systems. But really, Dee Dee, you brought this point up, like fundamentally, actually several folks brought this up. Fundamentally, there's an issue with data to even do this, right? When we think about demographic data and collection, there's a gap there. And then even data sharing with all the different entities that exist in our ecosystem. So can you all talk a little bit more about what you are doing at your organizations to make sure you're Black maternal health initiatives, programs, work is really being integrated into some of these other payment reform and also data collection / sharing initiatives.
So one of the things that one of the teams that in the Health Transformation Lab at Blue Shield is the Payment Innovation Team, right? And so in addition to trying to find innovative ways to help improve overall quality of care and access to care, equity in care, right, and the standard of treatment, and equity in terms of, I guess, what we are making available to our members is definitely something we're making a part of every one of our payment models, everything we make, right? Thinking about how do we try to make sure minimally we don't double down on inequities that exist, and maximally we're doing whatever we can to create equity. One of the things that we are doing with one of our provider groups is on a value-based payment model where we are actually doubling up on the incentive to close care gaps for, people of color, right? For Black people, it sounds crazy that you need to incentivize someone to care for the people who need it the most, for the people who have the most egregious disparities, but we do. And this isn't, again, not to blame anybody. It exists, it is, and we'll do what we can. And we are incorporating it into our value-based payment models, into our incentive programs and things like that. But it isn't just limited, right, into payment models, right? We have to think about it when we are writing contracts for networking, when we are thinking about how we compensate these very providers that Melissa's talking about. Can they even be a part of our network? And if they're not a part of our network, are we creating opportunities to be able to leverage their services, make their services available to our members and community members? And this is some of the work that Blue Shield teams are doing, right? Like if we have to direct invoice for this, we have to call it a billable event and not a claim, then that's what it is, right? And then we figure out the business of how do we operationalize this and systemize this so that this isn't just a single case based on a single story, which, let's be honest, that's how we all live today, one mom's story at a time.
We're doing something very similar at LA Care. We've been doing value-based purchasing and reimbursements for years. We're now adding an equity award. We're actually looking for our providers, and we're going to incentivize them further if they demonstrate that they're actually using an equity lens in their practice. They're actually creating and innovating how to look at these issues better. We'll start with incentivizing. We'll also go to education and try to re-educate providers and make sure they're clear. And we're trying to see how well those work before we look at other more punitive measures. I do believe, though, that it's going to require, I saw one of the questions in the chat box about how do we connect leadership and health system leadership with people on the front lines. I think programs like this begin that dialogue where we can open up and do that. We had a conversation yesterday with the CEO of Martin Luther King Hospital in Watts. And one of the things she talked about was care deserts. And what those are is places where the payment for care is so low that we cannot attract the specialists, the obstetricians, the neonatologists that we need to keep these communities safe. So we're planning on having a meeting with her very shortly, but we've got to look at a different payment mechanism. Right now we have the most vulnerable population of people in any part of California, where those doctors receive the lowest amount of pay, lower than Medicare, lower than commercial, and then we expect them to flock into these communities. They can't make a living. And so that's part of the challenge. We structurally created a situation by payment, by plan design, that mitigates against poor communities getting the care they need, and therefore we're adding to the risk factors for Black maternal health and infant health. So that's got to be addressed and addressed soon.
I would just say that, I look at this question maybe just a slightly different. For the work that we were doing around, racial justice and health equity as it relates to Black maternal health, really became a question around how do we put more Black women at the table and really into a workforce pathway that really represented our voices from bottom to the front lines, right? From top to the all and everywhere in between. And so that's what we started to do. We know that the one way that we can start to turn around the results when it comes to Black maternal health and infant health is if we were to have more Black women, more Black people inside of the health, actually taking care, represented at every aspect of the care for that mother and that family. And so how do you build more folks that are in that pathway? We started a doula strategy that really worked to make sure that we could build our own doula network right here in Sacramento, that it becomes not just a question of care, but how are we actually going to create economic justice for the families in these neighborhoods that need it the most. And so by creating and partnering with Blue Shield and really thinking about how do we create a workforce pathway that's focused on the ultimate care for Black women, and actually creating an economic justice strategy alongside of it, we've been able to have some really good wins. And in line of what's happening with SB 65 and the Mommy Bus, we're right in line to make sure that we can really take advantage of not just the incentives around being a payer that can have these type of outcomes, but a whole economic justice strategy that just doesn't focus on care, but is really upstream when it comes to how do we actually create a strategy where we're working not just on the holistic care of families, but the holistic care of whole neighborhoods.
I absolutely, oh, sorry. Sorry, I was just going to say, I absolutely love what Kendra put out there, and a couple of things I would love to pile on, which is, I hope that we can all think of the work that we are trying to do here with and on behalf of Black mothers as less about charity, because I do think that it kind of gets lost. And I saw questions about how do you counter the resentment that people have for the extra effort you're asking them to put out for Black moms. And I think it's interesting because we're all having this anti-racist discussion too, right? And it's like, to me, if you are leaning forward with your ally stickers and all that good stuff, and you are raising anti-racist kids, this is not different, right? This isn't, you aren't being anti-racist because you're charitable. You're being anti-racist because, well, you should. And you're making the extra steps, you're leaning in, you're doing your own work. And this is the same thing we have to do in healthcare, right? The own work, not the assumptions, not the, I'm going to give them something, I'm going to make available something for them. And then one other bit that I would love to tag on too, I'm a big fan of James Baldwin, right? And he has that quote about, if you alter the way people see the world, even by a millimeter, you can change reality. And I'm a firm believer, right, in this idea that of what Kendra was saying about putting in the path of everyone who walks the path from the path to motherhood, putting in that path a Black woman, a Black doctor, a Black doula, a Black call center operator. You change the reality of what that care is. And they don't even have to put on big programs, make, amazing things like, some of our panelists have made here, right? They just have to be and know and have lived the same experience. And I think that that's some of the work that we as payers can do, is put those people in these women's path.
Absolutely. I couldn't agree more. I think that this idea around this being something, a good work to do as a charitable effort, as something that is more morally good, and therefore we should all strive for it. And because we get questions like this about, well, what kind of resentment are we, at risk for engendering? This is good business. In healthcare, we have a responsibility to take care of everyone. And when we keep people well, we all win. And I have had to make this argument as someone who is building a for-profit tech company in maternity tech. I have to deal with this, and I had to deal with this since I founded the company. I've had so many people, not just Silicon Valley investor types, sure, yes, they're out there, but I'm talking about closed door meetings with leadership at medical centers, leadership at insurance companies, leadership in spaces and in public health programs at the state and federal level that say, yeah, this is really important, this is really nice, like we're trying, we definitely want to do something here. And to have to call it out repeatedly is exhausting. And I know a lot of people listening in today know how exhausting that is. We have to continue fighting for this. And I have had to become, I would say, very creative. My background is in law and policy and business, and I have a JD and an MBA. I don't come from the world of healthcare, although I have had a lot of exposure to maternal health through my own mother, who's a co-founder and business partner of the company, who's a nurse and lactation consultant, who's worked in this field for over 40 years. But I myself did not come into this from healthcare, delivering healthcare. I came into it because this seemed like a problem that I couldn't understand why it wasn't being solved, why it had not been solved. And for years before I actually started building Mommy, I watched the news, I read the reports, I read everything that came out from the CDC and every other maternal care quality collaborative, every chapter across the country to say, okay, where's the needle being moved? And you've heard us all talk about how difficult it is to actually move that needle. So there is a compelling nature to this that like I said, I've become very creative in how to make the pitch to different people in different spaces, because there are many pitches to be made. But bottom line is that it's got to be done. The thing that I wanted to point out in all the work, all the things we're talking about here, and maybe also it's an opportunity to share some details about some particular partnerships that we're all doing on this call, is that there really needs to be a concentrated effort to build out, not just at the plan level, plan design, as we talked about here, but systemic design that takes into account these touch points that have all been addressed. And it's great to shout them out and share them in conversations like this. But what everyone can do who's listening into this conversation can take these touch points back and challenge their teams, their leaders, their colleagues to make sure that they're answering those questions as part of a design of any program. That's where a lot of times we see great vision, but poor execution, because we may not want to talk about the dollars and cents of it, but we do need to talk about that. We need to figure out how we pay people better and more, and specifically, we pay Black women to do this work in these spaces. They're, like I mentioned, workforce development programs that are coming up, but if they're not connected to the larger, massive federal and state level initiatives that are happening with organizations like Blue Shield California and others, it doesn't matter. You have income disparities, and you have greater healthcare disparities, because there's a lot of people doing work over here and a lot of people saying, yeah, we should really be doing the work over here. And so anyway, this works me up, because connecting the dots is, it is the hardest part. You can have all the ideas, but you have to get all the people in the room.
Also is that the whole issue of concordance between Black patients and Black providers. So we have an Elevating the Safety Net program at LA Care, where we actually are recruiting physicians. We're paying for medical school debt. We're trying to get new minority physicians to practice in LA County, because we don't have enough doctors. And so we're doing what we can to recruit doctors, to pay the school debt, to get them involved. There's also another service that we're collaborating with called Black Doctors List, which is a for-profit company that is actually finding Black physicians and listing them on the internet so the patients can find the doctor they need. And that Black Doctors List has better data on the whereabouts of Black physicians than any of us do in healthcare and health plans. And so we're trying to find these innovative entrepreneurial work that's going on. But I just want to touch base on one thing I heard. This is more than just, and I agree, it's more than just a charity that we're asking for. And we're not really, we acknowledge that this is clearly business. We got to put the dollars where it is. But from a medical point of view, as a practitioner, this is a moral issue. This is what we're seeing is personal and corporate malpractice in terms of how Black women are being ignored, how they're being treated, and how we've designed systems that are giving the exact outcome that they're designed to give, which is the death of Black women and Black babies. That's, to me, a moral issue that has to be addressed. We've got to call it out for what it is. It's structural racism. And if we don't call it out, then we'll keep dancing around it. It's ugly in terms of what is causing this. And we've got to shine brighter lights upon that and then collaborate together to work on it.
There are a lot of amazing leaders on the line today and who are committed to eliminating structural racism, systematic racism. And then we know industry collaboration is so important in actually that fight and moving it, right? So one, how can folks on the line collaborate? You all are collaborating with one another, with others, and a lot of creative ways. Maybe if you could just touch upon that, and we can do a speed round and move to audience Q&A. Melissa, do you want to go first? I know that Blue Shield of California and Mommy have a very exciting partnership, so maybe you can kick that off.
Yes, thank you very much. I am pleased to share that we are launching a partnership with Blue Shield California to do this very work, starting in Sacramento County, and really building on so much of the effort that has been started by Kendra, and work now most recently with Sacramento Kings, but specifically with Sierra Foundation, with Her Health First, and with the various partners to these community-based efforts, perinatal health in Sacramento. So this is something where Mommy will be both a tech and service partner in amplifying these efforts. Ultimately, what we're doing is connecting the various organizations. Those are federally qualified health centers, those are birth centers, medical centers, and those community-based programs, doula initiatives, community health advocates, and all of the players through the Blue Shield network that can be active advocates and participants in this through the community health transformation program in the lab. So this is about connecting those dots, bringing those folks into the platform, and giving the community-based and allied health professionals the tool set needed to be able to document, to be fully a part of that continuum of care, to have not just their patients' voices heard or their program participants' voices heard, but their own voices heard. Getting back to that idea of we need to actually elevate everyone who has a view, a lens, a perspective on what's really going on in the community. So this is the first step toward actually making that possible. And what it will mean is that instead of having, as an enterprise organization, Blue Shield, needing to go to every individual program participant as part of this regional initiative to support Black mothers and infants, instead of having to go to each place and say, okay, what are you doing over here? And can you report back on all of this and all this stuff? And what are you doing over here? And how many people did you see? And what did you, to be able to have that in aggregate as part of a comprehensive view of how this community is functioning, who is doing what, who is carrying the weight. We all know where that is happening already on the ground, but if we can actually put that in writing, if we can put that in a view of health for that community, we're going to be able to start to model that in other communities as well. And we're very excited to take that work to other parts of the country. We've actually been doing this for the past year in DC, in the DC metro area with the DC Department of Health. We've been doing this with Los Angeles County Department of Health Services, really connecting the dots and care within these different care models. And so the next step here is to do this with with a payer leading this space and do a regional health initiative.
At LA Care, we are collaborating with doulas as well as midwives to put this program together to try to do some more in the community than we're now doing. But I think what we're going to need is a collaboration between all of our health plans in Southern California to create I would say, a registry of Black perinatal, obstetrical, pediatric, neonatal experts who are committed, who have concordance with their patients. And I look at the number of people on this call, though many of them are from outside of the state of California. There are people out here looking to get involved. And I think we should open our doors as health plans to say, hey, call us, let us know what you're doing. How can we collaborate? The meeting we plan on having with Martin Luther King Hospital is essentially, how do we help? Where do we step in? And I think Blue Shield, we work with Blue Shield Promise as one of our partners. We collaborate together. And people say, well, how can competitors collaborate? Well, we're talking about life and death here. It's not about just business, it's just life and death. And we believe that our philosophy is that if we collaborate with others, we can go further down the road than we can go alone. So we're looking at ways we can collaborate, and we're very excited about it.
And I would just say that, again, given yesterday's unprecedented signing of SB 65, California is again leading the way. You might ask yourself, why would I, switch from kind of health, racial justice, philanthropy to sports and entertainment? For me, it is an economic justice switch. I know that there is no way that we can change the outcome for Black women unless we start to understand what is the workforce pipeline that we can start to put Black women into and change the conditions that they can raise their families. And that's really important. And so in SB 65, I hope that you are really looking at the maximum ways that you can start to create a doula care network that can maximize billing. There could be community health workers, they can be certified mental health cares, and they can be doulas, all wrapped up into how do you maximize your billing efforts. You think about what's going to happen in medical reimbursement now and being able to really draw down those dollars so that you can create, again, workforce pipelines specific for Black women. They're going to help them not only be healthier mothers, but also have healthier infants healthier families. And so right now is unprecedented. I'd encourage you all to get involved in whatever California Department of Public Health is going to put down as ways that they can draw those dollars down. Really, Perry has had the most wonderful pilot initiative on how do you become a community health worker and a doula? What does that look like when it's wrapped together? Again, maximizing billing and making sure that Black women are leading the solutions that are closest to affecting them and their families. Thank you.
All right. I think Dr. Kyle gave me my quote, right? I'm supposed to say, I'm here to listen. And we're here to help. And so what can we do to help you, right? Let's work together. And I think Blue Shield absolutely is saying that to every partner, to everybody who does want to participate. And I want to echo what Melissa said, that this is a systems approach, because as I think it's Edwards Deming, right, who says systems get the results, are perfectly designed to get the results they get, right? And so if we want ours to continue to get the results we're getting, then let's continue to work in silos. But if we want better results, let's design better systems. And we'd love to partner with you to do that.
Yeah. And if you are interested in partnering, definitely please reach out and we can get you the information that you need to get connected. So you can email industryinitiatives@blueshieldca.com. It's also the direct reply if you reply on the Eventbrite. If you are interested for that, reach out. And of course, please follow everyone on LinkedIn that's here. And you can also reach out to the panelists directly. I wanted to ask, and I think this is a really important question because there has been a lot of attention on this topic recently with celebrities like Beyonce and Serena Williams and really amazing celebrities coming out and speaking about this. But how do we keep the same energy for when Black maternal health has trended out of the hot issue spotlight?
I think the energy around this subject is actually increasing. I don't see it decreasing anytime soon. I think people are getting fired up. And people are getting actually angry at what we see happening going on. And so I would doubt there's going to be any diminution in energy around this. The question is, can we move aside the partisan, the silos, and actually begin to talk across sectors with one another in ways that can build and be constructive. And that the right answers are all of our answers, not just, they don't belong to one person or one organization. We all need these answers because, quite frankly, we're not making the kind of headway we need to make. I see the energy is going to last for a long time.
I think that for me, it is asking folks to stretch, right? It is, if you consider yourself to be an ally, if your organization considers itself to be progressive and leaning forward, we are asking you to stretch. And in that, really making sure that you're not, just listening to Black women, that is good, but also making sure that Black women have a place at the leadership table when there's decisions being made, as well as really creating solutions. And that has always been very important for, our ability to move forward. And so if you're in that allyship, to really pull someone up and to create space.
And I would say my last bit on this is to think about not just sharing our information and pooling our efforts so that we can have compound impact, but let's also open our books a bit too, right? Because I think about ESG investing, right? That's a no-brainer for people. It's a big money, builder, and no one, doubts for a second, right, that there's a good reason to do it. We have to get more creative about the solutions that we design, or at least the ways that we keep the good going. And so I would definitely invite us to invite more people to the table to think about how do we keep the good going in addition to pooling the good.
Amazing. Thank you all for joining today. I'm really, really sorry we didn't get you. You all had, first of all, the chat was incredible. Thank you for engaging in that and sharing your personal stories. It was what sort of made this event, to be honest. These incredible panelists, thank you so, so much. So I loved the conversation. I know we didn't stay on schedule with our questions, but I think the conversation was worth it to diverge. And for folks again on the line, we'll be sending out the recording for this event. Please do share with others that may have missed this, that would like to hear this information. And again, reach out if you do want to collaborate in some sort of way. If you want to learn more about any of the programs that were mentioned today, we can connect you to the right folks. Thank you.
Thank you.
Thank you all.
All right. Bye-bye.
Thank you.